Good evening, colleagues, and everyone that is attending. I was asked to give you a talk on the female sexual dysfunction. This I always come across every time you walk around and guys, colleagues ask you, I have this problem, this patient with this problem, what do we do? It is a very complex and challenging problem that we need to have knowledge on, at least have an idea on how to go about it should we come across patients like this, especially in our clinical practice. So I'm going to start with the background. What do we mean by the female sexual disorders? So when the background, the view of the definition, what means sexuality? This is very important part of an individual's life. Is it boosts one's self-esteem, and also one has the sense of fulfillment. And then when it comes to sexual dysfunction, the sexual function on its own is very important in human's life, especially in determining the quality of life. Therefore, with that, once it becomes dysfunctional, then it impacts on that quality and one's self-esteem. Sexual dysfunction, by definition, being the inability of a person to experience sexual arousal, achieve sexual satisfaction under appropriate circumstances. It is basically a sexual behavior, a sensational disorder that manifests as a lack of sexual psychology or physiological response. Next slide. It may become more of a problem since the start of sexual activity or be required later on in life. It can affect both. It doesn't only affect females. Tonight we're going to talk about more focus on the females, but it does affect males as well. And it can either be due to psychological problems or even medical problems. So how does one respond, or the sexual response cycle? How is that? It started from being a non-sexual, then some become sexual. Once you are sexual, then you have the desire, what we always say, increased libido. Then you have libido, which is a desire. Then you become aroused, followed by following arousal, then will be orgasm. Following after that, everything goes back to normal resolution, where it goes back to non-sexual state. And the refractory, this will happen mostly in males. I just put it there as part of the sexual response. So it did happen mostly in males, where it goes back and the cycle starts again. So there are a couple of things that can motivate one what happens before the response. In some places, other cases could be just because of reward, whether being emotional or physical satisfaction. Following that, this will motivate someone to have sexual intercourse, and there must be willingness as well to engage in such activity. Following that, then there will be sexual stimuli, and in the context, there will be information processing by the brain as to now it's time to be aroused. Then remember, if the psyche is not there, the arousal most often does not follow. So with the brain has processed it, it says, I think now it's time to take over, and then someone become aroused. Then as a result, then there will be a response, and then the cycle goes back again. Then there will be orgasm and resolution, so on and so on. So it's the same cycle response actually, but everything is processed up there in the brain. If the brain is not processed and it's not there, then this tend to be affected. This most likely from where the psychological part comes in. Then we have the sexual dysfunction. This is basically a psychiatric problem, as it's categorized the DSM-5. In the next slide, the coming slide will show how it was trimmed from being more the way we used to you have the sexual aversion disorders, hypoactive sexual disorder, dyspareunia, and vaginismus. So this was in the DSM-4. Then when it comes to the DSM-5, then they were merged together. The sexual aversion disorder was removed from the diagnostic categories, and the hyposexual disorders and female sexual arousal disorders, they were meshed into female sexual arousal and internal disorders. So in the vaginismus, which cause pain, so it was meshed into a genital perineal pain disorders. So they eliminated the others. They end up with 3 instead of the previous 4 that we used to have from the DSM-4, and they meshed into make one condition which we probably thought would be easier to manage and to deal with. For one to have all these symptoms to say qualify for the criteria, the symptoms must at least be present at least for 6 months, and the experience of the presenting disorder, it should happen at least 75 to 100% of the time. So if it happens less often, then it doesn't meet the criteria for what to say, no, this one has got the sexual dysfunction. And at least with any other psychiatric condition, the disorder should have caused significant distress in an individual for it to be considered to be added as part of the diagnostic categories. So the problem affects about 30 to 50% of women, and it's mostly age related. So with increasing age and duration of the marriage, then there's increased prevalence of different forms of female sexual disorders. I found this a bit interesting, but I'm not discouraging anyone to stay in the marriage for longer, but it's just with the science. Says the longer you are in a marriage, then you tend to have these problems later on. And also with increasing age, also affect the sexual response cycle. So people might just stay in marriage. I'm sure there's a way you will talk about the management of that problem later on when you come to the treatment on how to go about and deal with it. So also the physical and the psychological pressures due to poor sexual satisfaction also can lead to the sexual deviation and health problems as well. The dysfunction will really affect the marital satisfaction, can cause conflict, ultimately can lead to a divorce. So it is integral part of any marriage or relationship, I guess, from what the science has said and proven from what the evidence is telling us. So I'm not saying marriage is that, but it's part of it. So the other concept that has been missed, it affects all women of all ethnicities. So it doesn't choose or which ethnic group normally has the problem. So everyone, as long as you are a female or a male, you can have a problem regardless of where your ethnic background. So the common condition that has been messed with is that there's a hyposexual disorder. This is one of the commonest condition in this group. So is a persistent or recurrent deficiency or absence of sexual fantasies of desire for activity, cause marked distress and also or interpersonal difficulty. It is estimated to affect at least 1 in 10 women. So this is very common. 1 in 10 is a small number. So it is a very common problem that I think most of us in private or other in the clinical practice we have came across patients like this. So the low sexual desires that comes with it is associated with emotional or psychological distress. As I've said in the previous slide, I alluded that it also to have low self-esteem ultimately leads to depression. So this can be a very serious, lead to more serious, other serious psychiatric problems if it's not dealt with earlier. So what are the risk factors for someone to have this sexual dysfunction? As I've said in that slide, the one of the previous slides, that everything comes from mostly the brain handles everything, and if the brain has not processed, as I've said, and then it's not ready, nothing's going to happen. So if you have psychological problems like anxiety, depression, psychosis, no matter if the body wants to, but as long as the brain is not ready and it's not happy, then it's not going to happen. We will be just fooling ourselves, and that's why then the conflict arises. Also, the conflict in a relationship, this also have a psychological problem, psychological effect. Also, then can lead to a sexual dysfunction, fatigue, and stress. Stress, again, it goes back to a psychological dysfunction, psychological effect as well, which also affect the same problem. And also, from the medical point of view, it also, if you have a prior physical or sexual abuse, this will lead to a sexual dysfunction. So these are the risks of sexual dysfunction. Mostly, if you can see, although it's still medical, but it's more of psychological. So medically will be if those patients that are on selective serotonin reuptake inhibitors, those who are tricyclic antidepressants, these are those patients that are on your Prozac, your Tripilin. We will always give these patients especially the tripling. I'm struggling to sleep. Then we end when you don't know what to do and you don't want to give benzos, then we give the Tripilins. Patient always on Prozac we prescribe for different conditions. This can affect the sexual response cycle. Also, your antipsychotic medication, benzodiazepine, this we can also affect the sexual response cycle if they're taking for a long time. As a short course, they shouldn't have that much effect, but if it's taking as a chronic method, it can have that effect. So the patient should be counseled appropriately in these cases. So then the other medical conditions, your endometriosis, this will more on the pain side. Diabetes mellitus, and we always talk about it even on the streets. I think even the laymen on the streets, once they say diabetes, they say, I know diabetes is going to be a problem. So then this will affect the medical point, the medical part of the sexual dysfunction. Next slide. I think you went a slide back. Yes. So this problem is more common in postmenopausal. We're not saying that the premenopausal women in men cannot have this problem, but is a common postmenopausal problem. Hence, even when the treatment is designed, is focusing more on the menopausal women. So I guess they expect everyone in the premenopausal to be very active, that they don't need to be treated. So unfortunately, it does happen. We'll see in the coming slides. But the menopausal women is because with aging, there's a decline in the hydroepiandrosterone and there's a decline in the testosterone levels. Also, as we know, the sexual desires declines with age. This is due to also the endocrinology of a female lifespan. When there's with postmenopause, there's decreased estrogen levels, there's decreased androgen levels. We know this is due to there's a chronic FSH, LH that is chronically elevated, that tend to have a negative effect on the hormone, on these hormones. So with the declining estradiol, this it becomes very chaotic in the perimenopausal period. These are there's the time where now that transition from the premenopausal to the postmenopausal period. With then the estrogen, there's withdrawals, there's increased tissue fragility, there's vaginal infections, then they tend to have UTIs. This also leads to vaginal dryness, urogenital pain, and susceptibility to trauma. This is attributed more to with the vulvovaginal atrophy, and this will affect the sexual response cycle overall, and therefore leading to the dysfunction, which physiologically this should happen mostly in the postmenopausal period. Next slide. As I was explained that the declining androgens secretions is just due to chronic elevation of the LH, and also the adrenal dehydroepiandrosterone that also declines with age as the woman grows older into the postmenopausal period. So what are the common sexual problems that we normally women encounter? Is lack of sexual desire, is lubrication difficulties, can be arousal deficiencies, inability to reach orgasms, or lack of pleasure in sex. This is what we in the clinical practice we come across these problems. So now here comes the patient with the sexual dysfunction, and he has all this the problem that I just listed in the previous slide. How do you go about it? First, history is very important. We need to know the history. We said everything is processed in the brain, so we need to know the sexual history. If there was a history of sexual abuse and the physical abuse, this can affect can lead to sexual dysfunction. Then we do the medical background as well. Can there have any history of coronary vascular disease, diabetes mellitus, depression, and careful attention should be to the presence of significant comorbidities and or the underlying etiologies is very important, as this together with as much as in most of the cases the problem will be more of the psychological, but medical condition also should be given an attention as well and be managed as such in order to alleviate this common condition. Next slide. So then we have the female sexual the disorder. This one is composed of 6 categories. We have the desire. It basically just goes back to the reference point will always be the sexual response on that sexual response cycle that I put in the first few slides. That will always be the reference point. If there's a problem with the desire, arousal, lubrication, orgasm, satisfaction, pain, those are the conditions that belongs to this group. So we need to get as to which one is the problem. Is it the desire problem? Is it the libido? Is it the arousal? Doesn't get aroused if the female doesn't get aroused? If there's not enough lubrication following the arousal, if do they reach an orgasm? Do they get satisfied? Or is it painful? If it's painful, we need to know again, because we need to exclude the medical problem. Is the superficial problem, which dyspareunia, or is it the deep the dyspareunia, which will, in that case, then we will need to investigate further as to what could be happening in the pelvis. If it's just superficial, could be because just the atrophy or just problem of the lubrication. Next slide. So once you have done that, there's a scale that one can use to assess the severity of the condition. It's called the female sexual distress scale. This was revised in order to help to come. If you're not sure, then you asked these questions that I've listed there, like the distress about the sex life, the unhappiness, the guilt about sexual. Then you score according to what the scale that you see on the right side. So the higher the scale, that means if someone scores more than 11, then this patient, then that will be the patient with the female sexual dysfunction, and now need to be given the proper attention and be managed based on whatever being. If it's psychological, then we need to psychological problems, psychotherapy. If it's a medical problem, then we deal with it medically. So following that, after that, having asked those questions from a history, now you've got the history. Already used the scale as well. It is already happening. Already you have an idea of what could be happening. Then we need to exclude, we go to the examination, because now it's time to exclude the medical problems. Assess the patient in general and just do the systemic evaluation, exclude any systemic problem that this patient could be having from the medical point of view. Then we need to check the gonadal function, to check the vascular competence, the neurological integrity, and also if overall check if the genital organs are normal, because somebody will be, in this case, it is in atrophy. Then you need to check if there's that atrophy, and if the hymen has been broken as well, then we need to check all those. Then while at it, then we assess for any STIs, because we know, especially some conditions like your candida, a common condition like candida, this patient tends to have more pain, especially for intercourse, and as a result, they don't get satisfaction. So the satisfaction will be probably one-sided, and this will cause distress first to the female, then to the male partner as well. So those are the conditions that we, while at it examining, we need to rule them out. So following that, then we need to investigate. We talked about the diabetes. So yes, part of the effect, to do the glucose levels. We need to check the cholesterol and the lipids. So then we can do just the hormone profile. I think that the hormone profile, I've not put it as one to be done for, especially for patients with female with a sexual dysfunction. It will just give you an idea if even the menopausal period you expect in the menopause for the LH to be highly elevated. But in a premenopausal, unless if somebody is showing the symptoms comes as a complaint of your vasomotor symptoms, then you probably want to check the hormone levels. And the X-rays is just for completeness to check if especially the menopausals, just to check the bone structure for the risk of osteoporosis while at it. So management will always be a multidisciplinary approach. This is a very complex condition. So we need to manage the psyche, we need to manage the physical part of it. So it has to be at least have a psychologist there, a psychiatrist, and the physician, meaning from our side as well. So we might need the social worker, as you see that it also had as an impact in marriages. So we need all the counseling that we can get from the team. So the first will be the counseling. So this is just to allay the anxiety and the embarrassment in discussing sexual problems. Of course, we know that this is not a comfortable topic to be going around and talking about it, especially from the male side. I mean, from the male side, I think is a very difficult topic to talk about, even amongst peers. So the main thing is to make them feel comfortable when they come to consult, so that they become open and answer the question in order for them to get help. And we must not judge these patients when they come in. We must reassure, inform them. If you see, the prevalence is very common. 1 in 10 is a very common condition. So if we have the treatable causes, then we treat counsel the patient, then we can manage those medical conditions. Next slide, so part of the team is to manage the psyche. I think this, above all, this is the most important of them all, because once you're able to control the psychotherapy, if you pass this stage, mostly the medical will probably be touch-ups, especially for us as gynaes, will be, once this part is done, then it will probably be easier for us to manage the other organic condition. So a couples therapy, and then if need be, then you refer to a sex therapist, depending on what we found whether being the problem, being the arousal problem, being the orgasmic problem. This is where the sex therapist, and they come and show this patient how to go about it, and in order to improve the condition. So a psychiatrist and psychologist will do with the evaluation and manage the psychiatric problem. If the anxiety, depression, others, that's where they come in and they manage the problem. Then the cognitive behavioral therapy while at it. Then lifetime modification also plays very important role. Those are always, let's say, the guys who are like jogging, and normally I just say the guys who like chasing air for no reason. And the other part of exercise, as Magula will tell you, that with this mountain bike, that exercise actually does improve the sexual being, and also yoga and some relaxing techniques. All of them, they improve the sexual function and that response. So I think that after this presentation, I will not be laughing at the guys who are chasing air for no reason. So probably maybe join them as well, like chase air for no reason. We know that's got some benefits on the other side. We said it, marriage is very important, and this keeps the marriage going apparently. Also, this will also improve the body image, and also, well, of importance as well is the pelvic floor physio. Women, especially those with the vaginismus patient and the dyspareunia, those are the patients that they learn to relax, and we need to relax. Then that's where the physio comes in. This will help in improving the sexual function. When that part, the main part, the major one that has been done, that is just for us to come and shine, and as if we know what we are doing, and we just come, especially in the postmenopausal, then we give scripts, and everything goes well. Then for those who are in private, will get more patients because of from the referrals. So especially in the postmenopausal women, the common drug that we give that one is being studied can be testosterone. The drug that is there, the methyl testosterone, you can give it in oral, 2.5 milligrams to 5 milligrams daily. This or you can use the testosterone patch. which delivers 300 microgram, give for 6 months, especially those women that are on estrogen therapy. This improves the sexual desire, the arousal, and the orgasmic problems. So for those patients, this way it has been studied. Actually, they got studied mostly more for the postmenopausal women. So far there are no limit studies that came across on the premenopausals. So especially when it comes to especially with regard to the androgens. Next slide. And then comes the estrogen. The estrogen, do they really help? When I'm sure we know with the Women Health Initiative study, in the subgroup analysis, they did not find an improvement in sexual satisfaction when patient uses estrogen. And also the menopausal hormone therapy for menopausal symptoms has been found this also to improve the sexual problems. The drug that I think this one to me is a scapegoat. If you don't know what to prescribe, then you just go for Tibolo. It's called Livifem in trade. The trade names is Livifem. If in the postmenopausal period, if we don't know what to prescribe, we tend to prescribe this drug, hoping that it will help. So it did not get an FDA approval with the cancer concern, but however, it appears to be more effective than progesterone and the estrogen therapy for the treatment of sexual dysfunction in women. This is due to this androgenic activity that also helped in this patient. So if you don't know what to do and you don't know where to go, we tend to run to Livifem or Tibolo. The dose is just 2.5 milligrams a day. Now, so the one that we come across, which is very complicated, is the premenopausal. By the look of things, it looks like the premenopausals were not supposed to experience these problems for some reason, but yeah, then it's happening. And the question is, what do we do? Because we know how to deal with, we know from the physiological point of view, we know why the postmenopausals are struggling. But what about the premenopausals? Can it be psychological? If psychotherapy doesn't work, where to? Do we have options when it comes to pharmacological therapy? None of them has been actually, none of the androgens in the premenopausals has not been advocated for premenopausal women. I did say in the slide the physiology of why actually it should happen in the postmenopausals, not in the premenopausals. But however, we do have some options then in the premenopausals. It's just unfortunately, especially in our country, most of them they are not available. The drug that has been found to be very effective by the FDA, approved by the FDA, is flibanserin. It's a central acting serotonin receptor agonist and antagonist. When given 100 milligrams at bedtime, it has been found to increase the dopamine and the norepinephrine, decrease the serotonin in certain areas of the brain, and then this will increase the sexual desires, especially those who want low sex drive. Unfortunately, we don't have it as yet. So the day it gets here, I'm sure it will be very popular very quickly when you get there. So we don't have it as yet. So then we have the bupropion. This is called the Zyban. This is the one that people who are tired of smoking now, they want to quit. They use this, they smoke this Zyban or bupropion. It's approved for the treatment of depression and smoking cessation. These are the primary treatment goals for the drug. But fortunately, the other effects that it seems like they are benefiting us as well. It's not FDA approved for the treatment of sexual dysfunction, but sometimes I think these are one of the few times where we will like the side effects. You just take it so that you can have those side effects, unlike other drugs. So is used in SSRI-induced sexual dysfunction. Like I said, it's an off-label indication. Here, we're just enjoying the side effects. As I've said, it improves the sexual arousal, orgasm completion, and the sexual satisfaction. So, is this one we do have in the country. So it's something that even if you are not a smoker, but you like side effects, you take it. So then we have the buspirone. This is typically used as an anti-anxiety medication, and is helpful for those patients with decreased libido. Again, there's another drug that is there that does help, but we don't have it. I don't know why our pharmaceuticals in this country, they don't order this. I don't know if they enjoy it when they see the high rising levels of divorce. So someone should do something about it, and get us the flibanserin and the buspirone so that we can reduce the divorce rate in this country. Then we have the bremelanotide. This is a melanocortin receptor agonist. It's also approved for the treatment of hypersexual disorder and in the premenopausal women. And it's given as an injection, 1.75 milligrams. It must be administered at least 45 minutes before the sexual activity, improve the sexual desire and the satisfaction. Again, it is with great sadness to say, we also don't have it. So it's still a struggle. Yeah. So now the depressing passes, we have this one that everyone else likes, the phosphodiester 5 inhibitors, sildenafil, also aka Viagra. We have it, but there's no evidence that it works. So clearly, is a losing battle. So there is still no evidence, especially in females, because we come across still more with females. So the results have been very inconsistent as a result. The evidence is very insufficient from the publications that it does help. So again, depressing. Then where do we run to? Then we go to medical devices. We have what we call the EROS. It's FDA approved, battery powered, is applied. This is just for the arousal. It's more for the arousal in the sexual response cycle. It supplies vacuum to increase the blood flow and engagement, and then increase arousal with the hope that following that, so with orgasm and satisfaction. So I don't know whether I should say it again, that is not readily available again. So is the problem. Next slide. So there are other therapies that have been tried, but the main thing, all in all, is psychological interventions. As you can see, especially I would say, especially in this country, where the pharmaceuticals, they focus on amoxil and they forget about the other, the social relationships, including marriages. So if psychotherapy doesn't work, chances are it's time to kneel down and pray to God that save my marriage. Next slide. So then we have the sexual pain. This would be the dyspareunia, the vaginismus. This could either be the problem with the lubricants, the moisturizers, and the vaginal, the estrogens, the estradiols, especially those patients with atrophy in the postmenopausal, the estradiol will help. If the problem is the superficial dyspareunia that I've said, then you can use the lubrication at least to improve the sexual function. Then those with the vaginismus, this is more the physiotherapists, those they come in, they do the physical therapy, can use the dilators, the myofascial release, and also for vulvodynia, we need to find the irritant and manage it as such. So, in summation, this is a very depressing talk because most of our patients are in the premenopausal period, and our pharmaceuticals, they don't take us serious. So the sexual function is a vital life quality, and as healthcare workers, we should initiate discussions into patients' sexual matters and assist accordingly. So it's counseling, make them feel comfortable, and so that they can talk freely. So the dysfunction is a common problem with negative effect on the quality of life, as we've said. So this we need to manage it. Throughout the talk, we've been showing that we need to really look after this patient, and psychotherapy, promote your exercises, your yoga. All this is just to relax the mind. When the mind is relaxed, anything is possible. But when the mind is stressed, then nothing happens. So we need to have all this and the knowledge regarding the diagnosis, treatment, especially from the medical point of view. Then we need to treat if there are medical conditions that need to be sorted. That's the end of my talk. I'll take any question. I doubt if there's anyone who want to ask questions after such a depressing talk.
No, depressing talk. We now know what's going on. Yeah.
Yeah, no, we have a big problem.
Yeah, no, and I'll advise everyone to get a bicycle, as Dr. Moke has just said, and also start chasing air.
Yeah, I think chasing the air probably is. I think I'm following now. I tried the bicycle thing, it didn't work, so I'm gonna try chasing air now and see if it works. Yeah.
That's great. Awesome.
Yeah.
Thank you so much, Doc. That was, quite a joyous and a fun presentation. I enjoyed it personally. Really nothing less than what I had expected. It was awesome, and I think you can see on the Q&A in the chat that people are really engaging. I just wanted to ask, when it comes to the duration of marriage, the longer the marriage, the higher the sexual dysfunction. So that we start counting down. What do the studies say? How long?
No, there's no duration. I think it boils down to comfort, where I think people then become comfortable, and there's not that drive, and I guess it boils down to that. So it simply means that when that day when you come to that altar, they say you must keep the fire burning. Every day is a new day when we are in a marriage, because once you become comfortable, then we're gonna have this problem, and which we will have seemingly no solution for, because we only have solution for the postmenopausals. But for our generation in our group, it's a big problem.
Yeah, I must say, if you are faced with a premenopausal woman that comes with sexual dysfunction, it's a headache. And
it is.
We don't have many sexual, I don't know what you call them, but
Therapists.
Sexual therapists or sex therapists, going around in Nelspruit, in fact, where we are. I don't think there's any. I don't know in Gauteng they are really available. And as one can tell, this is a multidisciplinary type of intervention that's necessary. Yeah. Sure. No, awesome, Doc. So there's a few other questions. I think some of them we've actually addressed, such as the use of testosterone in sexual dysfunction. You've covered that. But there's a few questions around the possible causes and maybe contributing factors, such as the use of contraception. There's one attendee that's asking if the use of Depo-Provera is associated with sexual dysfunction?
No, actually it's not. Especially the depot has got some androgenic activity, so it doesn't have an effect when it comes to it as part of the cause of sexual dysfunction. So it is a bit more potent. So it is not one of them. So it's more psychological again, I think.
Okay, and then diet. Is there any diet that would actually put them at risk?
Not that in the studies, I haven't come across anywhere they talk about diet, but I don't think it should be much of a problem, especially because what we know is those with your soyas, where they say there's high level of estrogens in it. It really shouldn't have that much effect is in the premenopausal. As I've said, actually, looks like the premenopausals where no one considered them that one day this will become a problem to the premenopausal. So diet, I don't have any evidence on that one, but I don't think there should be any.
Okay.
Alcohol?
It's a whole long. Okay. I'm sure it does. I'm guessing. I think it does. And smoking.
No, smoking. You've got a treatment. You treat the smoking part, and then you enjoy the side effects. That's very healthy.
The bupropion, eh?
Yeah, the bupropion. Yeah. So while you're trying to quit smoking, then you enjoy the side effects.
Lovely. There's a whole long list of contributing things like, hysterectomy. There's also a question about masturbation, if it does decrease libido.
No, then it shouldn't. Actually, it's part of the arousal. If you look at the sexual response cycle, so that will be a part of the arousal. So it doesn't increase libido. Actually, it should increase libido.
But Doctor, do you think people might get to be a bit tolerant where the masturbation does not satisfy the need anymore, and maybe that's why they feel depressed, that they need something else more than what they're used to? I don't know.
Especially when you consult the sex therapist, what they will tell you is that if it will be for those guys, they say start with yourself. If the problem is an orgasmic problem, if your problem is another arousal problems, they say start and find your spot that will work for you. It's part of counseling and the psychological or the psychotherapist. So I think that's why the sex therapists, they use that more often to manage this kind of cases.
Okay.
But from our side, we don't have that enough evidence. So the evidence is just more of the sex therapist and the psychotherapist overall.
Okay, cool.
So with regard, there's always going to be the question of size. I see someone had asked. It always comes back when you talk about these things. So the question is, does it matter? And there's also another question that sort of links to that, where they are asking whether one could consider herbs or some, alternative medicine for enlargement. I think this all boils down to the issue of size. Yeah, I don't know what your opinion is on that.
Remember, in terms of the enlargement and that, it's not about. I don't think it's not about the size. It's about preparing the brain for the activity to follow. If you look at, I think my third or fourth slide, I show that part of it is the brain processing. So even if it doesn't matter whether the size is bigger or is smaller, but the brain has not processed and it's not there, you're not aroused, there's no arousal, size will not matter. So it's all about the brain, for as long as there are no medical problems. If the brain is there, there's always around it. And I didn't say part of the problem is penetration. Remember, there was no any of my side when I talked about penetration. I think size they're asking in relation to penetration. People do reach orgasm even without penetration. So I don't think it's not that the matter of the size, it's about the brain being ready and trying to lay the message to the appropriate organ, which will respond to the in accordance with the activity.
And maybe coming back to the issue of the brain, doc, there's a question. I think it's a doctor who works in a mental health institution. She or he says they've got a patient there who's literally, he says he's hypersexual or she is hypersexual. She's even going to a point of sexually assaulting men in the unit. So this is sort of the flip side to this. I don't know your opinion on how they could approach this. She has sort of suggested possible treatments such as spironolactone, androcare. Your opinion, or what would be your response to that, doc?
Yeah, it's just that now this one is a patient in mental institution. If it was not that, otherwise it was going to be a good problem. So now this could be a patient. I hope this patient is not taking the drugs that I was talking about, then the SSRI, the one that blocks the action of the SSRIs and the TCAs. Anything that counter effect those drugs, then it will automatically increase the libido. So, but in those patients, I guess what we do, if you give anti-androgens, the problem is also, remember, they do also have side effects. So it goes back again to look history, look what the medication is the patient taking. Maybe taper that and see if that will help.
Okay. Awesome. Thank you, Dr. Tamawela. I don't know if you have any other questions. I see there's quite a few there.
No, I wanted to just check whether sexual orientation plays a role, because someone was saying we were not very inclusive. Not everyone engages in heterosexual activity. So maybe, I don't know, your experience around that. I know we have an upcoming topic with the Prof. Lindick on this transgender, gender non-conforming, the whole complex. But yeah, your comments, Doc?
Yeah, I think if the talk, as much, that's why I say I didn't include the male. I didn't want to prolong the presentation further, because if bring the male and so it was for the topic was female, but if with that female, if you can again, let me apologize for not others feel that they felt excluded, but I didn't talk. I don't remember any of the slide where I talked about penetration. That means whether even being homosexual or heterosexual, there's no penetration. It's basically the response cycle, the sexual response cycle, where whether being a male or a female or anyone else, then as long as they say desire, there's arousal, there's orgasm, and there's resolution. It's not about the gender, it's all about the sexual response as it is.
Yeah, and I see Ismail is still sitting on the issue of size, and I think the basic answer is that size doesn't matter. It's all
size
in the
doesn't
mind,
matter. Right? Size doesn't matter. It's all in the mind. It's all in the mind.
It's all in the mind. Yeah. Let's see if Sibongiseni wants to add to. Sibongiseni, your hand is up. I don't know if you want to ask a question live. If it's a mistake, please lower your hand. I'm going to try and give you talking rights, Sibongiseni. Sibongiseni, you may unmute if, yes, okay, so it's a true hand, yes.
Yeah, greetings to the panelists. I hope, am I audible?
Yes.
Yeah, just to reiterate some of the comments that have been made, to say thank you so much for this presentation. It's quite enlightening. And honestly speaking, I graduated in 2017. This is the only second presentation on sexual dysfunction and sexual health that I've ever attended. The one was in 4th year, and this is the only second one. So I think part of the reason why most of us don't engage patients on sexual issues and issues of sexual dysfunction is because we lack the knowledge. And I think between that time when it was probably around 2014, 2015, up until now. There's been a lot of developments. So just to say that maybe we should look at involving, I know this is not the correct platform, but it's things that wherever in other platforms where we have access to, maybe to raise these things, that we really need more presentations like this. We need an involvement of issues of sexual health, because it's one of the main issues. And because we lack the knowledge, and patients are even scared to raise these things, because in most cases, the only answer we have is sildenafil. We don't know anything else. So I think we appreciate this opportunity, and yeah. And then maybe in terms of sexual therapist, I'm not sure if Dr. Mwagi knows any available courses, or if this is the correct platform to say that you can actually do these courses, because I've actually looked it up. There's not much available in South Africa when it comes to sexual therapy or sexology. Thank you.
Thank you. Thank you. We appreciate the feedback, Dr. Mwahi. Where can I go to become a sexologist?
Thanks, Punzen. The problem is another, unfortunately, like you said, it's very difficult for people to talk about it, and hence the few that we have in the country, there are those that went abroad to do these courses, and others just a matter of doing the certificate outside the country to do the certificate. I don't know of any institution in the country that offer sex training, but there are few sex therapists that I know. I think they did their studies outside the country. So this, but truthfully said, I think it's a topic that everyone is not comfortable talking about it. Being the patient, being like anyone else, they are not comfortable because of the low self-esteem that it comes with, and not being comfortable as a result, especially from the male side. Males even worse than the females. But anyway, there's a bit of help that is there. In terms of the therapist, I think in Pretoria probably there are one or two around this side that deal purely with the sexual problems.
Superb, Doc. So maybe a question for me is that I didn't hear you mentioning urology. Is there a role of a urologist in this space, or it's a pure guiding?
No. If you check the full presentation that I sent you there, I didn't talk about male, but there are a few slides on the male. Might come in handy when it comes to the male side, especially if they were to deal with.
All right, I think we might
Okay. Yeah, but from the female point, is us and the psychologist, psychiatrist, and sex therapist and physiotherapist.
All right. Colleagues, let's take one more hand, and then Dr. Magagula will announce the next event and the topic we are going to have, and then we try to call it the quits. Zakaria, you may unmute. You are the last hand for the night. Zakaria? Zakaria, are you there? All right. I don't think Zakaria is able to unmute.
Can you hear me?
Oh, there we go.
Oh, yes. Hi, Zakaria. Sure.
Hi. I just wanted to find out. I was stuck with a case this other day. A lady, the main problem was that she could not feel anything during penetration, but she can experience pleasure during foreplay, touch, and everything, but then during penetration, she doesn't feel anything. Now she's worried.
I think, but I think we've got the gist. Those are the cases that I would think you probably need to exclude the medical problems as well. I've talked about the common conditions that we come across is your candida infection, your yeast infection. So which is more of a big of a problem. So we need to exclude those are conditions that we need to exclude if in that cycle the cycle. There is one drug that I didn't talk about, the aromatase inhibitors, your ospemifene. Also, it does help in those cases, given 60 milligrams a day. Also, is one of the drug. If there's no other organic or medical cause, then it's something that can be given to consider. Ospemifene 60 milligrams is very difficult to get it, but maybe it will be one of your pharmaceuticals that do have it. Ospemifene is an aromatase inhibitor.
On this very same patient, or could it be that perhaps for her to complete the sexual cycle, she doesn't really need penetration, but she seems to be, responding with pleasure before penetration, but when there's penetration, then it all stops there.
Exactly, because you see, there's a desire, there's arousal, and then there's the orgasm part of it. So I fully agree. Probably penetration you don't need penetration to complete the cycle. So you can have the penetration. Same happen with the same sex couples. They do complete the cycle without penetration. Maybe penetration is not for her, but I think we would still exclude the other conditions as well.
Absolutely. And maybe before we close, Dr. Mawela, I see a question from Prof. Matzila. She's asking, do we have testosterone patches in South Africa? Or
I think we have.
Okay.
The patches we have, yeah.
Okay. No, awesome. Thank you so much, Dr. Moahi. I think this was quite a very informative talk. We really need more of this. It's a woman's right, to enjoy her sexuality and function well within a relationship from a sexual point of view. And I think you've really covered all aspects of this topic only in an hour. So we really appreciate your time. And thank you to the attendees, the audience. You've been amazing. You've interacted and asked, the key questions that we get asked in the consulting rooms. So we really appreciate the time that you've, spared to be with us here on the platform. The next coming one, as Dr. Mawela mentioned, we'll be having Prof. Lindeki discussing gender dysphoria. So it's all issues around issues of gender, ethics around it, and what interventions are available for those people that need intervention. That will be coming on the 7th of November. Really looking forward to that one. It's different. It's exactly like this one. And I think it's going to be great as well. Thank you so much, colleagues. And